All right. I will note that Commissioners Chung and Chow are here. We can move on to the second item on the agenda, which is the approval of the March 2nd, 2021 Finance and Planning Committee meeting.
And I would so move.
And I would second. So we would adopt the March 16th, March 6th meeting.
Yes, and I'll note there's nobody on the public comment line who's not involved, who's not been invited, so there's no one to make comments. Item 3 is the monthly contracts report.
Hello, good afternoon, Commissioners. I'm Michelle Ruggles, the Director of the DPH Business Office, and I will walk through these, and we have staff for most of them on standby to present. So beginning with YMCA, SF Hope is how we distinguish that from other YMCA. The requested action today is for approval of an amendment to this contract. The current Health Commission approval is through June 30th, 2021. So we're trying to extend it for 1.5 years through December 31st, 2022. It's fairly straightforward. The funding matches the extension period, and hasn't been too long since we were last here with this contract, but the program serves 4 Hope SF locations and neighborhoods with community wellness programs, including Sunnydale, Potrero Hill, Terrace, and Annex Alice Griffith and Huntersview housing development. And if you have specific questions, I would turn it over, assuming I think he's on here, to Mateo Lumbreras, the director of that program.
Commissioners,
Yeah, I'm just wondering now that I just saw this. Each of the field staff members, of which there are 16, receive a certain salary. So what do they actually do, if you can remind me? I know it's a good program, I can remember that, but I'm just trying to think of, there are 16 staff people. Is it that the 16 have 16 different sites where they're operating, or is it sort of within an office complex, or what?
Is Mateo on here, Mark?
let me see. I don't see, if Mateo is one of the people on the line, if you could press *3 so you can raise your hand and I'll know that's you. Otherwise, I do not see that person.
Well, that's all right. You can probably get back to me. I mean, I remember the program was a good idea. I just sort of looked at that and said that, you know, they're getting about $100,000 per year. I'm sure they're worth it, but I just was trying to picture how they were doing their work.
Okay, let me find out and then get back to you with more detail.
Otherwise, I don't have any more questions about that. That was just sort of suddenly struck me that it'd be kind of just to refresh my mind. Thank you.
Okay, thank you. Okay, so I'll move on. The next contract is Instituto Familiar de la Raza, and I'm your backup person on this one. So what this contract is being amended specifically to add in the COVID funding, which is all that this is, and we're trying to get caught up and get all of the COVID funded contracts to you. When they start, it's always an emergency, but this particular contract, we added 1.4 million. It was an increase. There's a little typo there in the description, but so if we've added 1.4 million, $69,376, and specifically 1.2 million of that is for the COVID-19 Latinx Collaborative. And so Instituto, working with other collaborative members, for example, Mission Neighborhood Centers, Centro Latino de San Francisco, and Cultura, I'm dying about my accent, but Arte Nativa de las Americas, CANA, are all part of this bilingual and bicultural collaborative that is working to bring health outreach and education, case investigation and contact tracing, food services and wraparound services to Latinx community members. So that's the bulk of that funding. There's another $35,000 it's paying that is for the development of a community resource and recovery action plan. And then there's a little tiny bit of 5,000, which is staff that actually do the case investigation and contact tracing work have a salary bump to make them commensurate with a department, civil service classification, health worker. And so that's been this whole other side project is calculating that amount out, but the department has provided training, and then those are our, our partners that do this work in the community. So essentially that is what this change in the contract is to add in the funding that was added for this purpose in the city's budget in 2021.
Any questions, Commissioner?
Commissioner Chow?
Yeah, you mentioned there was a typo within the first column, so I was wondering, you mean that
Where
there's an annual difference of 600%, or where?
No, the difference, the typo was, let's see, in the purpose. Okay, so in the purpose, the first sentence says that this is increasing the contract by 2.4 million, but
Yes.
actually the increase is 1.4 million. So that was the typo. The top line that says 951,000 up to 2.4 million with an increase of 1.4 million. So the 1.4 million is the new COVID funding plus the contingency. So the increase is 1,469,000.
So, however, in the little box above, it talks about a difference, which we're talking about the 1 year, of 1,290,000.
So the 1,290,000 is the annual amount. The 1,469,000 includes the 12% contingency.
Oh, okay, all right. No, thank you. That's fine. I was just trying to see where that'd be a clarification, and the chairman would probably also. But I just happened to pick that up right now. Thank you, and I wanted to thank you also for this is a good place just to say that the reports on the contractors here came out very positively, and thank you for getting those in terms of
sure. Okay. Good to move on. Okay, all right. Then the next contract is the San Francisco AIDS Foundation, and this one is the rental subsidy. So while this is a new contract, it's the same service, which is why we left it on this report. I think we agreed last month that if the service isn't the same, we would pull it out and have it be a standalone memo, even if the agency is the same. So this service is continuing essentially what has been provided. We're proposing here a 2-year contract, and it continues by providing monthly financial assistance in the form of rental subsidies to clients with disabling HIV or AIDS, including those who are imminently homeless and HIV positive clients, to help them maintain stable, safe, and affordable housing. And the agency received perfect scores for the prior contract that is ending. So, and we shared that. This will be anyway. So that's that. And in general, like we try to do every time, if we have an extra large contract, we bring that list to you. So we provided a list of the full funding for the SF AIDS Foundation. Well, we've reported out on this contract that they've done. We reported actually out on both of them. In general, just to make the statement, which we did last time too, they're in good standing with their contracts. And Joseph Chettere is here if you have any additional questions about the rental subsidies contract.
Any questions, commissioners?
I don't have any.
Commissioner Chung, anything from you?
No question for me.
Okay, great. Thank you.
All right, the next contract is also the San Francisco AIDS Foundation. This is a contract from CHEP, and the request here is to extend the contract from its current end date of June 30th, 21 through the maximum term allowed under the solicitation. So that would be through June 30th, 2025. The funding essentially is funding the baseline, you know, plus or minus add backs that come in and come out or carry forwards, but so it's basically the same funding level. And what this contract does is provide support for HIV-informed hepatitis C outreach and linkage to care services through the general fund and project opt-in, which is funded through the CDC. The contract overall has monitoring scores of 4 that they exceed standards or 3 meet standards in their prior monitoring report. So we have no problem and support the extension. And we have Hannah Hjord from HIV, HCV, STI Behavioral Health Coordinator if you have questions.
Commissioners, anything? Oh,
Not from me. I was a little bit confused at first because I thought we've talked about like 10 years contract is the maximum. And then I saw that the year is 2016 to 2025 and then changed to 2030. So no question.
Okay, thanks.
The only question I have here is that you said that we were moving this along, and that was fine. And you're correct if we'd use this format if it was either an extension or a similar contract for a new contract, but it was the same services.
Mm-hmm.
But I'm wondering, you're saying that this was the same, but it says it's going to increase the total contract. So I'm just now trying to read. Oh, here it is. You're saying that the linkage to care would be the new program. Is that right? Just clarifying that. For the extra 205,000 difference?
Yeah, the linkage to care, the second contract is an extension of an existing contract. It's not a new contract. The first contract, rental subsidies, the one that's 9.4 million, that's the new contract. So the San Francisco AIDS Foundation, the second contract, the funding change is the addition of 2021 continued CDC funding, a one-time general fund amount and 30,000, an additional 4 years of funding. And you're right. I don't know. Maybe Hannah knows. I don't actually, now that you brought it up, see the breakdown for the annual increase.
Well, I do see it here. There was a footnote, so I apologize for.
Oh yeah.
Yeah, it says it was CDC additional funding of 245,000.
Right. Yeah.
So, thank you.
Sure. I just enlarged my screen. Okay.
We have so much information. Sometimes I see differently, but and again, I want to commend you for the descriptions and everything that we're getting because it's really quite helpful.
Thanks.
so that's the last contract then on the report, isn't it, Ms. Ruggles?
Oh, Edgewood.
I have Edward Center on here.
Oh, I'm sorry. I thought you were talking about that.
We were talking about the AIDS Foundation second contract, I think.
I apologize.
Okay, so this is the last one, the Edgewood Center for Children and Families. This is a big behavioral health, children, youth, and family contract. And you could see how many programs are in their contract, how many different solicitations are in their contract. And the funding that we are requesting and the extension that we are requesting includes all the programs until they time out with their solicitation, and that's described under reason for funding change. So if all of these services, through all of these different solicitations, were ongoing, the contract would be much bigger even, but it's not much bigger because once the solicitation ends, then we don't continue the funding automatically because we will have a new solicitation. So, but anyway, as you can see, this contractor, Edgewood, who is a long-term contractor with the Department of Public Health, provides many services, counseling, well, you can read them. And we included the performance monitoring for you. If you'll notice it's from fiscal year 18-19, which most of these are. One change, and that I'll bring to you, I'm trying to get an overall summary across the board, is that because of COVID, while we are still going out or desk audits and reviewing the performance measures, we are not scoring them because it's just hard to have a meaningful score during COVID. But anyway, this is a program that we're very reliant upon. And if you have programmatic questions or any questions, really, I'd like to turn it over to Allison Less-Bader, who is an assistant director in Children, Youth, and Families for Behavioral Health Services.
Commissioners, any questions?
Well, they do. They certainly do a lot of work, and we understand that 1920 there has not been, of course, the client satisfaction and realizing the population they're taking care of. I wonder if staff would comment that the clients they're taking care of probably aren't necessarily people who really are pleased. But is that the reason for the ones and twos under client satisfaction 2 years ago? I mean, it's just because the population doesn't really want to be there and therefore they're not very satisfied? Or was there some sort of work that we've asked them to do to correct those?
Well, we have found that in a lot of our residential treatment programs where kids are mandated to go there, they generally all score about that, the ones and the twos, because the kids will never say, yeah, I'm so happy to be here. This is the best place ever. Thank you for helping me. So we found that that's true in a lot of our residential programs. And so we've kind of taken that into consideration on those client satisfaction questions. Because we did look into that. I think it was the year before that, because we were noticing a trend.
Okay, no, thank you. That was just a guess on my part, but you people have done the study to really confirm that you're right. If I were a kid that was sort of mandated there, I don't think I'd be necessarily giving you a 4, right?
Right. Now, yeah. So we kind of looked at it because we did see a trend in a bunch of those kinds of programs. So yeah. So look, you were right.
Okay, thank you. I have no other questions. We know that they're a good contractor and been working for us for many, many years. And obviously, they have taken on a very difficult population. So thank you.
Thank you.
So since the contract report is done, Commissioners.
Do we have a motion?
Right.
Yes, I would move that we recommend the contracts report for the commission.
Okay, thanks. And I'll second it, and we will add that to the consent calendar for the next meeting.
Thank you. Item 4 is the request for approval of a new contract with National Research Corporation.
And I will just turn this right over to our DPH representative, Nicholas. I call him Nick Gonslaves by Salve. to present this.
Dawn. Oh, okay, so I'm good. I'm just making sure. Okay, thank you for having me today. So the contract that we're talking about today is for a patient and workforce experience survey. The patient part of the survey would be just related to getting feedback on how how well our providers are doing in providing care for our patients. NRC is going to, I believe, give sort of instant feedback. The other side, which I'm a little bit more familiar with, is the workforce experience survey. This is sort of something we've actually been doing since 2015. We've had surveys. We had survey in, I believe, it was 2015 with NRC. Then we had a survey in 2019 with Prescani. We had a pulse survey in 2020 that we actually did ourselves. And now we're excited to bring back NRC for our 2021 employee engagement survey. The plan would be actually to survey our staff every single year. The odd years will be the years that you actually have a full survey of approximately 60 questions, and the off years will be sort of, the even years will be more of a pulse survey of no more than 20 questions, just to understand how our staff are doing. And as far as the survey goes, we've actually had some pretty good participation in the survey. In 2019, 65% of our employees and partners complete the survey. Even in 2020, we had almost 50%, 45% participation in a pulse survey, given the circumstances of a lot of people working remotely and just sort of some of the logistical difficulties of getting some staff to complete the survey was actually pretty impressive. Does anyone have any questions about this contract or about the employee engagement survey or the patient survey in general?
So I guess you're describing that we're going to use two different instruments, which I'm glad to hear that we're going to be doing something every year. So this is not the, well, which one is this? Is this the Pulse as versus the Gainey survey? Is that?
Right now is we're about to enter our full survey in 2021.
So this is the full survey that you're submitting to us?
This is the full survey. So we've dropped our Prescani, the Prescani contract. So we're out of that contract. And now our new vendor is NRC, which is a vendor we previously had. Now we're returning to that vendor again.
Oh, I see. Okay. I know that you had gone on to Prescani because I remember the report regarding it and all, and that's why I was a little confused. Is this the Prescani or not? But this replaces the that one. Okay.
Yes, that's exactly it.
All right. So that's fine. That was an RFP, and you guys all decided that that was the right move to make. So appreciate that. I don't have any further questions. Pleased that you are going to go on a regular schedule for the surveys.
Yeah, and that's exactly it. And tentatively, we're trying to get the survey together for October 2021 this year. So that's our goal, at least.
Okay, I have no further questions.
And I don't have questions. So do we have a motion?
I would move recommending for approval to the commission.
Okay, and I second. So we'll add that to the consent calendar as well.
Thank you, Commissioner. Item 5, and thanks, Nick. Item
Thank
5,
you.
a request for approval of a new contract with Richmond Area Multi-Services Incorporated.
Hello, it's me. I get to present. I am presenting today on behalf of Angelica Almeida and Ron Candler, who are both on vacation. But the executive director from RAMS and I believe the director of the division of their peer-based services are here if there are additional questions. I think it was just last month that we presented a new contract with HR 360, which was to provide the behavioral health clinician membership of the city's new street crisis response team project. And so this contract today with RAMS is to fund the peer provider member of the team. And then the other member of the team is a paramedic. So if you remember, to remind you, the Street Crisis Response Team is a new initiative called for under Mental Health San Francisco that requested the development of these teams. And these are citywide teams, and there will be multiple, eventually, I think 6. They'll operate 24/7, 7 days a week. And the goal is to provide an alternative response to law enforcement for nonviolent behavioral health crises in public settings. And I know that I think it was supposed to happen, it was already supposed to happen, but it's been rescheduled before the Health Commission for April 20th. You'll have a full briefing on the, excuse me, the Street Crisis Response Team. So if you have like bigger picture detailed questions, but with respect to RAMS, they're providing, this is funding to provide the peer members. It's a 2-year and 2-month contract for a total amount of $5.3 million, $13,978. And I think you have in front of you that we have 6 contracts with RAMS. And we have within that 22 behavioral health programs that are monitored by the Business Office of Contract Compliance. And you also have that at the end of the performance. But of the 22 programs in 1819, I have a typo in my own notes, but 20 of them, I believe, achieved, 95% of them achieved the top score. So we're very happy with this contractor and happy that they're able to take this role, because it's a very important role in the rollout and effectiveness of this program. So that's what I can tell you. And if you have deeper questions about the programming, then I would turn it over to the contractor.
Any questions, commissioners?
Just want to clarify, RAMS will have 6 contracts after we approve this contract, right?
Correct, including this one. Yes, you're
Okay.
right.
Thank you.
Mhm.
It's really actually great to see that RAMS, those of us who are here who helped it survive, is really meeting a very vital need. And in this case, although we're going to get a whole description of the street crisis response, could they quickly just tell us what that peer counselor will be doing within it? Because we're understanding you're picking up people and it's been in the news and all. But then what role is it that RAMS plays that's going to be integrated into this? Are they going into residences, or these people come to RAMS, or how does the peer counseling work?
Hi, this is Hasyan Sanaga, Division Director. May I speak? I can answer those questions unless Michelle, you feel.
Yeah.
I also want to acknowledge I have a new CEO here at RAMS, Miss Javon Mohammed. She just started, so she's getting up to speed. So, but I will be able to answer the questions that you just asked, Dr. Chow. So in this project, the peers are actually, this is a unique model because it's the first time, it's a co-responder model in the streets to behavioral health crisis. So for right now, we're only addressing public settings behavioral health crisis, and our peers will be actually mobile. They are riding around in the vehicle with the paramedic and behavioral health clinician to respond to these public behavioral health crises. We are affiliated with 911, so 911 dispatching actually will forward calls to us that are appropriate for handling nonviolent behavioral health crisis. That's one way we're getting the majority of our calls. And then we also do on-views, which is basically our rigs will go into certain neighborhoods. It's geographically kind of mapped out when all the teams ramp out or roll out. And basically the peers role will be an equal partner with the medic and behavioral health clinician in terms of the medic takes care of the primary basic health, physical health needs. when we respond to someone in crisis. The behavioral health clinician will make an assessment whether to provide consultation at that moment or to provide linkage. And the peer really is part of the trauma-informed approach that DPH is embracing in terms of being able to de-escalate situations with mostly folks that are homeless, and in most of the crises are folks who are homeless on the streets. So there's been some indication that sometimes it's just not enough not to have the police involved and only having a clinician or medic, because there are a lot of people who are resistant still to less forceful, sorry, lack of a better term, but less invasive type of support. So we think that the peer will be able to even further provide compassionate care and actually help motivate someone to accept care. And so the long-term goal is to really connect very difficult folks that are resistant to services within the system to actually take the first steps getting into the system. And so far, we have very anecdotal information right now because we're only a few months in. Not all the teams are rolled out, but we're seeing a lot of folks who are recognized by service providers in the communities as those who are constant ER patients, and yet not receiving care in terms of outpatient or psychiatric care on a regular basis. We're seeing that we're able to address that because they're seeing us out in the street. The peer, again, has lived experience similar to those folks who are struggling on the streets right now. And there seems to be a real shift in terms of folks being open to receiving services. So that's where we see, that's what the peer is doing right now. That's the overall global impact we're hoping that these teams will provide. And secondly, they also will just, we want to be able to make sure that we're providing compassionate care. Again, a lot of folks refuse services because they feel like there's a lot of barriers, including being forced to go into services. So sorry for that long summary, but that's kind of what our peers' role is in this team.
No, thank you. That's very exciting, and I know we're all looking forward to a overall presentation, but I really appreciate, and this sounds like a innovative idea. Well, maybe it's not so innovative. Other cities may well have tried it before, I don't know, but it's very good for us to add that component, it seems to me.
Yes, I would say actually from what we understand nationally, there are a few cities that do have the non-law enforcement co-responder with the medic and a clinician or a psychiatrist or a psychologist with a medic. I believe the peer piece, which is the third piece, is novel to United States. So I think there's a lot of excitement and data collection in terms of seeing the impact that the peers will have in this three-team co-responder model.
Okay, very good. And ask your new CEO just to remember Dr. Evelyn Lee, who really helped, as maybe you probably know, continue the great work that RAMS today even does. Right.
Thank you.
I've heard. I just wanted to acknowledge your comment and thank you. I'm Javon Muhammad, the new CEO, and I've been hearing about her, and I hope to make her memory proud.
Yeah, and do you still have her book?
I'm not sure. I'm not sure.
She had a very nice book on, and convinced us RAMS was very important. And a matter of fact, Evelyn came and out of UC and was supported by the department to help RAMS, be able to thrive. So we're really pleased of all the work that you guys are doing, and thank you.
Thank you.
Thank you.
So commissioners, this contract needs to be approved unless you have other questions.
I don't. I was just speaking to myself without unmuting. Dr. Chow, do you have a motion for this?
Yes, I'd move that this contract be recommended to the commission for approval.
Okay, so and I second, and we'll add this to the consent calendar.
Thank you.
Thank you.
And I'm noting again that all the names I see on the public comment line are names that have been invited to the meeting, so I'm not calling for public comment on these items. Item 6 is a new contract request with Natural Languages LLC.
So, hi, it's Michelle again. So this is a request for approval, as Mark said, of a new contract with Natural Languages to provide as needed on-site interpreter services. The total contract is $409,173, and it includes the 12% contingency for an initial term of March 21st through February 29th, 2024. And I will, from there, just turn it right over to our department representative, David
Hi.
Dow.
Yes, my name is David Dow. I'm the interpreter service manager, and I just want to give a little background in terms of what we're doing here. We provide language service to all DPH units within City County of San Francisco, and we currently have 31 in-house interpreter staff. Most of our in-house interpreter are either Spanish or some of other Asian languages, because those are like probably cover like up to 80% of our total service need. And the rest of our service is for language interpretation is handled by language agency. Right now, we only have telephonic interpreting with the language agency, and we are in the process of upgrading it to video, but that's going to be for another day. And the reason for this contract is to address the service need in 3 different areas. One, especially during last year, during the peak of COVID, we lost quite a few of our staff due to health issues, and they were out like for long term. So if at the time if we had this contract in place, then we would use the agency interpreter to come on site to backfill the staff who are on leave. And when I say on leave, I mean, for long term, not like for a week or even 2 weeks. And the other reason for this contract is for the in-house interpreter, like I mentioned earlier, we mainly cover some of the 3, or I would say 5 top languages. And anytime when we need a language that we don't have in-house, we may be able to tap into this contract to bring in agency interpreter. But we are planning to use it for extreme cases. In other words, if something can be done over the phone, we will continue with using the agency interpreter over the phone. And the last part of this contract is to cover, as you know, we have different type of public meetings, and most of these meetings involve with needing the need of interpreter on site or in person. So we're hoping to have this contract in place, and moving forward, anytime when we get requests for a public meeting, we can bring in multiple interpreter to address the language need for this purpose. I just want to point out that the first part of the first reason why we have this contract, that it becomes less urgent now that in the first quarter of this year, we have successfully hired 7 new interpreters full-time. So in terms of for the backfill, the need is kind of somehow not as urgent, but we still need the interpreter from the agency come on site if we need it, if we don't have the in-house language available, or like I mentioned, for the public meeting. So I just want to see if you have any questions.
Dr. Chow?
Yeah, so why is there a differential in the rate between Spanish and the other core languages?
Uh, well, I guess that is just every agency is different. The telephonic interpretation that we're using right now, we get a flat rate. But with some of the language agency, especially for in-person, it most likely is based on the availability of the interpreter. And Spanish right now is, I mean, in terms of for our hiring here, we have no problem finding a Spanish interpreter for to fill our vacancies, but we are struggling with Chinese and other languages. So I guess it's just a demand and you know, it's even though the Spanish is high demand, but also it's easier for them to find interpreters.
Okay, no, thank you.
I hope that makes sense, but that's it's kind of like interpreter services. Sometimes they have their little bit of own universe.
Oh yes, well, no, it's a marketplace, and it's okay. It's very interesting that they break it out that way. But thank you.
And
You're welcome.
yeah, and thank you for that clarifications. And I guess the questions that I really have here is that because Chinese, it has so many like sub dialects. So
Yes.
how would you determine if there's any interpreter available for that?
Well, let me just use our in-house interpreter, for example. Personally, I speak Cantonese and Mandarin and Vietnamese, just because I was born in Vietnam. But most of our interpreter, yeah, people say, well, wow, how can you learn those languages? I say, no, I just born into it. But in terms for our interpreter here, most of the Chinese interpreter, they're multilingual or dialects. Most of our interpreter either speak Cantonese, Mandarin, and some speak Chinese. And like you mentioned, there are so many different dialects in Chinese. Those usually either if we cannot address the need in-house, we would go to language agency, and we do break it down to. I mean, for example, with Chinese, most of the time for monthly bill, we have them break down to at least, I would say, 5 to 6 different dialects for Chinese. But if you look for like the whole fiscal year, the breakdown of Chinese dialect would be like, I can't even count it. I would say at least a dozen, like Hakka, Hokkien and East Shanghainese, and all those local small dialects. They all have. I mean, we do have them available over the phone.
That's great. And actually, you know, that brought up a point. Is there any way for us to, like in the future, like look at these kind of breakdowns so that you know, like we know like what the trends are in terms of Chinese dialects, you know, like where we're heading.
Sure. Yeah, we do have that sent to the language office access, I think, a report sent to that office every year, but I'd be happy to provide that to the commission. You know, I can send it to Mark after the meeting with the breakdown of languages that we provided in the past fiscal year.
Thanks. No hurry. It's just my curiosity.
Well, if I don't do it right away, I may forget. So I will make sure I will send it out after the meeting.
Thank you.
You're welcome.
Dr. Chow?
No, I appreciated your question also in regards to and Mr. Dow giving us a really good snapshot of what we're looking at. I guess my only question I did see before. So, is this still residing over at General, or where are you located now?
We are right now. We have 2 locations. Actually, we have multiple locations, but in 2 buildings. our main office is located at CXN building on 25th Street, where HR is. And we also have, well, we consider ourselves as a call center. And then we also have 2 locations at the main hospital in building 5. And all of our interpreters are kind of providing kind of hybrid type of service. When they're not being sent out in person, they would provide service via either video or telephone service.
Very good. Thank you. Very, very essential service.
You're welcome.
I'll make a motion that this contract also be recommended to the commission for approval.
And I second, and we'll add this contract to the consent calendar. Thank you.
Thank you, commissioners.
Thank you, David, and thanks, commissioners.
You're welcome.
Item 7 is a request for approval of a contract with Visit Healthcare for end-to-end COVID-19 vaccination services.
Hi, this is Jonathan Sears at the COVID Command Center. So this is a contract that covers end-to-end vaccination services for COVID-19 that was selected under a DPH RFP process. And so really it's in support of our vaccine community access strategy to work with communities and provide low barrier access to vaccination services. And this contract with the end-to-end services, it's supporting supply outside of vaccine, so medical and non-medical supply, the logistics, the site operations, vaccinators, and so forth. So it's a true like end-to-end service that we're hoping to deploy to support community access to vaccine.
If I may then, how would they respond to the needs? And we just talked about the language issues, but even the cultural issues of the different communities that we're now trying to reach, either through, are they part of a mobile system, or would they, would you be using them to especially have Spanish if you're going into the Latino communities, or what? Because I don't see where they talk about their capability of reaching the cultural needs of those communities.
Thank you for the question. So there's part of the contract in the RFP was to request for like culturally competent services so that they can go into communities that have faced high COVID burden and impact. And provide low barrier access to these communities. Part of the model is that we work with community-based organizations and other community partners to provide like this level of wraparound support and services. And then Ben, who is the CEO of Visit, is on, so can clarify a little bit further as well.
So I guess the question is whether the contract does include those or includes only using the community for the cultural outreach.
Ben, would you like to clarify just from Visit's perspective?
Sure. So can you hear me? Hi, pleasure to meet everybody. So the question is, how do we implement culturally competent services? Is that right, Mr. Chow?
Yes, and in particular, yes, and particularly if there's either a language or a barrier that a community might have. For example, in the African American community, it might be, resistance towards government vaccines, and in the Latino community, it might be an issue of trying to translate correctly, and the Chinese being able to be a face to people that, or even be able to answer their questions. Or perhaps that's not what the contract does. That's what I'm trying to just clarify.
Yeah, that makes a lot of sense. Great question. So just a little bit of background on Visit. So we were founded in 2015. We operate in about half the states in the United States, and we provide mobile healthcare services this last year, we've been doing it all the way from Alaska to New York, Massachusetts. We're actually based here in the Bay Area. So it's great to be working in a community that we grew up in, or at least I did. I lived in the Mission for quite a while. The way that we handle the need for local community sensitivity and communication capability, from Alaska native language capabilities to Southside Chicago to San Francisco and Excelsior and Visitation Valley and so forth, is several things. So first of all, our management level people have a lot of experience operating in many different cultures and languages, but we do the vast majority of our hiring ultra locally. So for the sites that we have in Visitation Valley, Bayview, and so forth, they are, I would say most of the team members are hired locally in those communities. And from a language perspective, we are capable of, the written communication and instructions, we're capable of providing whatever languages are appropriate to that particular neighborhood. But also, since we're trying to hire locally from those communities, the people know and live in the community and are understanding of the specific cultural needs of that community.
Very good. And you say that, so how long, you were founded in 2015, so prior to the spread of COVID, you must have been doing other work because COVID wasn't here at the time. And you sound very experienced in being able to reach out to communities. Could you just give us a little feeling of the experience and why you then went into COVID?
So Visit is actually an offshoot of another company that we founded about 15 years ago, which was a healthcare staffing firm that staffed hospitals across the country, including the UC Medical Centers, Stanford Medical Center, Dignity Health, which is the largest healthcare system on the West Coast, all the way to New York and everything in between. And so that gave us the opportunity to employ very many health professionals from many parts of the country. And then in 2015, we formed Visit specifically to help with the mobile aspect of what in the healthcare industry you're seeing a move toward telemedicine, where things like taking a swab or doing a vaccination is not something that you can do over Zoom. And so the teams of health professionals we have around the country allow for the mobile deployment of those or serving as those needs. And so just over a decade and a half of experience in healthcare in many different places in the country, that's sort of where that cultural sensitivity comes. And actually, frankly, this project is a joy to be part of because it specifically is focused on underserved communities that might have a really hard time driving a car across the city to go through a drive-through site where they'd have to wait a lot of hours. And so personally, I feel it's a pleasure to be able to help in this specific project. Well,
Thank you. It sounds like it's been exciting work, and you have a chance to come back to the city.
Yeah, absolutely. It's been great to be back in San Francisco. I was in Alaska in the summer and Chicago as well in the summer in New York, and it's just great to be back home.
Okay. I have no further questions. I think I understand now the type of work we're going to have from Visit Healthcare. So thank you.
And I don't have questions. So
I will then move for the recommendation for the commission to approve.
and I will second the recommendation. So and add it to the consent calendar.
Thank you, commissioners. Thank you, Jonathan and Ben. We can move on to item 8, which is a request for approval of a contract with Bay Area Phlebotomy and Laboratory Services.
Thank you. This is Jonathan again. So this is the same scope of contract. So Bay Area Phlebotomy and Laboratory Services has been working in the mission at one of our neighborhood vaccine sites. And so they're selected under the same RFP as the secondary vendor directly to support our mission neighborhood sites because they had an established relationship with the mission community and had a lot of community vaccination success. So similar scope with regards to this vendor supporting our vaccine community access strategy.
Any questions, commissioners?
So on the unit tests, I'm assuming that the 2-shot regimen is actually per shot the same as the 1-shot regimen?
Can you repeat the question, Dr. Chow? Sorry.
Okay, well, the question is, you have written that in the contract is proposed that 2-shot regimens are $80. Now, I'm assuming that that's not for each shot, but maybe it is. And in that case, why? Because the 1-shot is only 40. I mean, I understand 2 shots for 40 each, but if it's $80 per shot, then why? I think you're muted.
Can you hear me?
Yes.
Now we can hear
Okay,
you.
sorry about that. Thank you for the question, Dr. Chow. The 40 and 80 is for the 2-dose series complete,
Okay.
not just the 1-shot.
No, just wanted to clarify that. Thank you.
Thank you.
Any other questions, commissioners?
Yeah.
I have no questions. Dr. Chow might have another one.
No, I was just going to suggest that we would recommend this to the commission for its approval also.
Okay, so, and I'll second and add that to the consent calendar.
Great.
Thank you.
Thank you again, Jonathan. Item 9 is a request for approval of a new contract with Episcopal Community Services. And I believe we have Kelly Hiramoto here.
Yes, thank you, Mark, and good afternoon, commissioners. This is Kelly Hiramoto. Today I'm here before you as a Deputy to Health Operations Chief at COVID Emergency Operations Center. This is a new COVID contract to provide isolation and quarantine services in a hotel and a congregate setting. Specifically, Episcopal Community Services is providing isolation and quarantine management and support to sites Y, which is the congregate setting, and at Site 37, a hotel setting. They'll be taking over administration and staffing of the sites by providing the frontline and operations support to maintain isolation and quarantine at those 2 locations. The ECS was selected under a RFQ that was issued by the Homeless and Supportive Housing Department in conjunction with Human Services Agency. And then a subset of that was isolation and quarantine, and DPH issued a supplemental solicitation for proposals. ECS was one of the respondents, and so were awarded for these 2 sites.
So is the intent, because I just noted there's a difference of months in the units at the site Y has a 12-month contract, but site 37 only has a 10-month.
Yes, that's because site Y opened a little bit earlier than the site 37, so it had a longer projected run than site 37.
Okay, so oh, I see. Okay, this is actually retro to December 1st of 2020.
Correct. Yeah.
All right, so we're just catching up on. They haven't been doing this for free though.
No.
Okay, so we're just formalizing the contract for this.
Right. Yes.
All right. Well, we understand with the emergency.
They're generous. They're not that generous.
Yeah. No. That's great. That's great. I don't have any other questions on this contract. It's obviously a service that's needed.
And I don't have any questions. Yes, and I agree. It's a really much needed program right now for the communities. So do we have a motion?
Right. I would move this one also for recommendation for approval to the commission.
Okay, and I will add that to the consent calendar.
Thank you,
Thank you very much, Kelly. Thank you,
Commissioner.
Commissioner.
Thank you, Mark.
Thank you.
Item 10 is a request for approval of a new emergency contract with Primary Diagnostics Incorporated. I believe
Is
Mr.
Eric?
is here. Eric? We've got him in the meeting, but I don't know if he is.
Looks like he has a camera, but I don't see that. But
Michelle, do you know anything about this to start us off while I try to get a hold of him at all?
I can read this.
well, the first thing is probably a correction of the contingent of the term, because it says it's January 31, 2022 to January 31, 2022, and it says for 11 months. So I'm not quite sure what the real dates are.
Let's see if I can find the memo. Yeah, that would be a typo. The 11 months is probably correct because it's a COVID, but sorry, I didn't have the contracts pulled up.
Hi, and good afternoon. Sorry I wasn't able to connect properly with you, but I'm here now. And I think this is Eric Raffin, Commissioners, Chief Information Officer for DPH. And I believe Ms. Ruggles is correct that this is an emergency contract under the Emergency Contract Authority. And so there is a limitation. There might be a typo in the wording here, and we can make sure that we triple check that for the actual limits, the term limits of the agreement.
Can you tell us about the motivation for the contract, Mr. Rasmussen, to give them some basic overview?
Sorry, yep, there was a little glitch here on my end. Sorry about that. Good afternoon again. Much in the way that you've heard from my colleagues, Mr. Emoto and Mr. Sears, about support services agreements to assist us with the remainder of our COVID response. This contract with Primary Diagnostics is similar. And the services acquired under this agreement are providing the information systems infrastructure to support registration, scheduling, vaccine administration, compliance with state of California rules, with updating vaccination records into the California Immunization Registry, as well as being able to provide us with daily intelligence on where we are vaccinating. The rationale for bringing in an additional entity to help us is that we realized in December, as we started vaccinating within the Department of Public Health, that we were going to need to be very nimble and be able to flex quickly to provide both assistance for more community-based vaccination sites, as well as our larger high-volume sites, such as City College. So we knew we needed an information systems platform that could be really a single purpose platform, be very straightforward, be platform agnostic, allow us to have very positive interactions with vaccinees across multiple languages, which were some limitations that we face with our EPIC platform, as we've discussed in other settings with regard to the EPIC contract. And so we're very pleased to be able to find an organization who could partner with us so that we could ensure that we could comply with all of the regulatory requirements for documenting a vaccine administration, but also be able to be culturally competent and language competent with how we are trying to bolster our outreach to communities where English is not the spoken language. You'll see the dollar value of the contract is high, and we left that headroom in there because we weren't exactly sure how many actual vaccine administrations we would need to accomplish using the tool, and part of the pricing model for this tool is a per vaccination charge. Happy to take your questions, commissioners.
So I guess I am trying to say in the infrastructure, let's say, and I took my wife over to City College. What would this be doing over there? I saw the nurses, I saw the UC people, I saw the guy with his clipboard who checks off things. I didn't see any computer or.
That's a great question, Commissioner Chow. So at the beginning of City College's work, they were on paper. And a very significant reason why we now have this agreement is that we needed to move City College off paper-based vaccine scheduling, administration, and reporting. And so if you were to visit City College today, you would see the tools from Primary Diagnostics in use.
Okay. That's a great answer. Thank you.
You're welcome.
I have no other questions, Madam Chair.
So, Commissioner Chung, any questions from you?
No, I did. Can you hear me now?
Yes, we can.
I forgot to unmute again. Yeah, no questions. So can we have a motion?
I would move that we have this contract also recommended to the Commission for its approval, without which we won't be able to do our advanced vaccination sites.
Yes, and I will second it and add that to the consent calendar as well.
All right. Thank you, Eric.
Thank you, Eric.
Thank you.
All right. Item 11 is the health equity impact assessment. And Dr. Bennett is going to present an example for you all. Commissioner Gerardo has also joined you. And if you all remember, Dr. Bennett presented first to the Community Public Health Committee the concept and paradigm. And so that's why Commissioner Gerardo is joining us. The floor is yours, Dr. Bennett.
Hello, all. I can't see myself, so I assume I'm on camera. We talked about a month or so ago about this requirement that is in our Racial Equity Action Plan. You as a commission are required to have a tool that you use to evaluate equity. They are common, so there are not common, but there are multiple possible tools. We looked at a handful of the more prominent ones and talked to the committee about what was good or bad and kind of settled on using the Government Alliance on Race and Equity model, which is the one that many municipalities use, and it is fairly well worked out and well known. In that discussion, I was asked to give an example to help ground how such a tool might be used. And so I worked with Paula Jones, I meant to text her to get back on if she's not on there, to look at an example of how we might use such a tool. And it was more instructive than I had expected. There were lots of little tweaks that were required for the tool to be used successfully. There were some things that need to be adapted for health more significantly than I had thought. And so we ended up doing some changes, and I think need to do several run-throughs to do more. So we had envisioned this as a fairly rapid process. We'd pick one, you'd say it's great, and then we move on. I think that this is more likely to be successful if it's a somewhat drawn-out process, and we expect that we will arrive and approve at a tool over a series of months rather than just picking one out of the box, because I do think the needs of the health department in terms of finances and what we mean by equity are unique enough that I think we really need our tool. So that is what you're seeing today. It is not just a run through, but a reframing also. So that's what the beginning is. So I wanted us all to be on the same page, particularly the commissioners who had already seen some of this presentation. I'm trying to share. Hold on a second.
Do you see the button at the bottom?
Hold on.
And if you have any problem, I'm happy to be back up.
Okay. So it won't let me do it, Mark, unless I get out of WebEx, and then I'll have to come back on. Do you have the presentation?
Yes, give me
Okay.
10 seconds to switch over and I'll be right back.
Thank you. Thanks so much. Thanks, Mark. Perfect. So go on forward. So this is what I mean by an extension. This is what I'd like to propose we do. We reviewed the possible tool some time ago. I spent some time developing and testing that with staff in the department. This is a meeting in which you're going to review that. I then think what the form we have of it now, I would consider our pilot form, and that we will train people on how to use that format and start that format being actively used in July. It requires community input and data and things that people really do need some run up to the presentation to be sure that they've put in. It's not just about how they present it or even how they talk about it. It is about how you conduct your programs and how they are developed. And so it will need to be phased in so that things that are already gelled, there's only so much that the tool can really be used for those. So we'll be looking at phasing it in, maybe a one presentation at a committee, at a full commission meeting, and you'll see it grow. We'll iterate based on what people do, change the training based on what people do. And then when I come back in November, perhaps having reported to the committee beforehand, when I come back in November, we can just say, this is the final version, which we will go forward with for years. So you will have seen it used for 5 or 6 months, but I'd like us to resist the urge to declare it the final version until later to allow us some latitude to change it. Go forward. Does that frame sit well? Does everybody understand what I mean going forward then? Okay. So I think that the tweaks were significant enough that I think I will reframe this as a racial equity tool, but mixed with a health impact assessment, because it really does need to focus on the health equity, and that health part has a little bit of a different slant than the kinds of problems racial equity tools are put to. They're used for city budgets, they're used to decide where a park would go. So they have multiple uses and they can stretch to that. This, I think, is a little bit of a more of a stretch. So the process is relatively similar. Everybody has a proposal in the health equity action plan, which is on the bottom there. You are going to be screening for when you need it. So it's meant to be that you're being asked to do it or you're out seeking them. Not every proposal would be eligible for that. In this case, I think we probably would do as many proposals as possible. So the next would be a data review for the GARE tool, and in the racial equity action plan, that means looking at historical data for the population, looking at data on whatever your problem is. So if you're doing transportation, who uses what buses, what is the racial equity makeup? That's a little bit different than a health impact assessment, which is trying to see how relevant it is to think that what you're talking about will impact health. So there are some things we do which will not have that direct a link, and it'll be much harder to assess how this will change an endpoint outcome of equity. It may change process parts of equity. Do people use the system in a more equitable way? But whether or not it has a chance of actually changing the percentage of people in any group that have heart disease or something, I think is a step further than just data review. So looking to evaluate, is there a scope of connection with health that can allow us to do this assessment? And some things I think will fail that. The Racial Equity Action Plan then wants you to do community engagement and use that community engagement to do some analysis about what will work or not work, what things might work. So it's basically a predictive process, and then how it might, how those things might be mitigated. So I think that that Latinx people won't use this service because it doesn't have good language access. You have to change it by putting in better language access. The health equity, the health impact assessment is somewhat different than that, in that it is really looking for quantitative estimates of impact. And I think sometimes we can push that far. So it's actually trying to say, this will increase heart disease by X. It's usually on a negative side of, this is going to have a negative impact, and trying to help people assess that. I think in this case, we're flipping it and we're trying to find out whether things will have a positive impact or not. And so those are relatively similar processes, and then they both have implementation. The racial equity tool is really meant to be used by the people who are doing the process. And so they take the plan they've developed and go. The health impact assessment is more of a recommendation from other people. We're sort of doing both, in that we are very often working with people who are not us to actually do the service. We're assessing plans that are made by contractors. We're assessing programs, but from the fiscal side. So we'll be doing a little bit of both depending on the circumstances, and adding those mitigations and judging those mitigations. And then accountability and communication. Racial equity tools really envision a deep community relationship, so that the community actually has power to influence what you do. So the community not wanting it there means you may not put it there. Health impact assessments don't really go that far, but they do want some community feedback and to report back to those people. In the racial equity tool, the report back is really an accountability step. So it's meant to tell the community, you told us X and we did it. Or we told you it would be this way and we had to change it, or whatever. The health impact is really meant to go to decision makers, and it does not envision the community necessarily as those decision makers, but I do think they're similar enough, and we have to do both. We have to justify it to electeds, to you, the commission. So we are also giving the kind of data that decision makers need, which is very different than necessarily the kind of information the community wants about how something worked. So we'll be doing a little bit of both as we iterate this model. Go forward, Mark. So we're going to do an example about WIC, and I don't see Paula, but I do see Priti Rani, who runs the WIC program for us. And if there are specific program questions, I'm going to let them answer. This model was not meant to necessarily show you a program. So this program might have been presented at some point, but that was not their original intention at this moment. We pushed them a little bit further. And so some of the answers we may not even have at this moment. So go forward.
And Dr. Bennett, just so you know, Paula is on the phone, but I'm unable to unmute her from where I sit. But I'm going to try to do that while you talk.
Okay. Well, we may not call on her. So just the overarching, what you're going to see, and you can say there, Mark, is a few of the questions in each step of the combined tool that we created. So these are 2 questions, there may be 4. So we did not go through we did go through every question, but I didn't present them all here because it would have been quite long. And we can give you a handout version that is the entire thing if somebody actually wants that. So the proposal, what is your proposal and its intended impact? So in our case, we would want that to be something that actually is impacting the community directly. It'd be harder to do this process on things that are internal or tangential. What are the health conditions that this proposal will impact? So in this case, it's expanding food security funding for pregnant people who are enrolled in WIC or Black Infant Health. And that funding is meant to increase food security, which we know poor food intake by moms or pregnant people is causing gestational hypertension, or at least exacerbating. So there are multiple conditions where you might see an impact by improving maternal nutrition. Go forward. And you'll note those are not process metrics of people will eat more. It's what's the health outcome that we're trying to strive for. We may not always be able to go that far. So there are several other questions about the proposal that we're skipping. The data review is both the kind of historical, geographic, social data that the racial equity plan would require, but also we have geographic and community-based health data, or we have the tools to generate that. And that may be important in a way that we have not really looked at. How much of the condition we're talking about do we know about, and where is it occurring, and who is it occurring in? We have lots of documented disparities. And so there's plenty of information already to know whether or not the health condition you're dealing with has a known disparity. In this case, perinatal health conditions are disproportionately seen in Black, African American, Pacific Islander, and some other racial minorities, but prominently those two. So, and those are the ones that I pointed to: gestational diabetes, preterm birth, those in that collection. And so other factors that are not race, but also do divide those people who have these who have those conditions, are people who receive Medi-Cal, less than a high school age, or people who are food insecure, receive Medi-Cal, residents where people are living in poverty. So there are lots of things that relate to our intervention that are not just race, and it'd be important to at least know what those are so that you can see what the comorbidities or the collateral improvements that we need to make. In this case, the impact is going to be felt in these communities that I outlined, and that's because that's where we see the communities that are highly Black, African American, or Pacific Islander, and some Latinx communities who have food insecurity that doesn't always translate into maternal or infant problems. Go forward. This is more of the data review, in that we want performance. Done this before? Has someone else done this before? Just looking to see not just the performance of the program, because we already tell you that when we have it, but what is the performance in terms of racial equity? There are many, many unintended consequences of doing interventions, because race and disparities and the way we've gotten our societies distributed along different lines is really complex. And so knowing whether or not you're going to cause an inequity is a very difficult thing to project. And so is there any data about that? In this case, they did do a program that was similar, that gave vouchers. Those vouchers did seem to be effective, and they were used by lots of people in different groups. So if you see at the top the way WIC, on the WIC clients, and then you can see various maps about who did it. This is not full data that you would get, but this is a shortened presentation just to talk about the tool, not the program per se. Go forward. Oh, go back real quick, Mark, and I'll let somebody interrupt me, I can tell. Odds of preterm delivery in one study did decrease with this intervention. So there is reason to think that if we can fix the intervening problem of food insecurity, we may fix our disparity endpoint. Who is that who is asking to speak? Was that me? My voice I was hearing? Okay. Go forward. So the community engagement is meant to be done at the beginning of the process. It's not meant to be an afterthought. That will not always be possible. Many of the things we do are mandated by somebody. So it's the state's tobacco control program, or it's some other entity has got a significant weight into how the program is run. And so what we're engaging the community about may be different. We may not have as much latitude as we would if we were placing buses. But in this case, they did do some. They did focus groups about food insecurity with African Americans, Spanish speakers, Chinese speakers, and then multi-ethnic English speakers. And they got some themes out of that that were useful in planning. So Latinx immigrants said that they had a fear of the public charge impact and exposure to police or ICE. Chinese participants wanted more protein than this vegetable program was going to give, and they want to use small Asian grocery stores. Black and African Americans also wanted more protein, but they need the benefits at income above, they're food insecure at incomes above the cutoff. So the cutoff is too low to really demonstrate who's food insecure. So all of that information is really helpful in thinking through, is there a group? So we're going to eliminate small grocery stores. Well, that disproportionately is going to eliminate our Asian participants, perhaps. And so that's the kind of thinking that people are supposed to do with that information. And what it's told them about factors that relate to the racial inequality that we see in food insecurity, housing, discrimination, shame, low income, immigration, language. So knowing which of those are problems, and then you should see mitigations for those. If they know that transportation is racially mediated, then if the program requires transportation, hopefully we're doing something to be aware of being able to cover all groups, and that we're assessing whether or not transportation was still a burden. Go forward. Analysis and strategy. So that's where you're supposed to take the information you got from community and your data and decide what to do with your program that will decrease inequity and increase equity. And that may be increasing the equity in who utilizes the program. That may be increasing impact on one group because they actually have a bigger problem than other groups do. So it may be trying to equalize things. It may be, in fact, making things different for different groups based on their need. And in this case, they learned from their research and their community engagement, and they learned that they would have better nutrition with this program. People do need it, and that it's not really going to address some of the long-term access issues. Those are broad. They involve issues that we don't have good control over. So we know it's going to have a limited impact because we know there are other issues that are really at play here. It's designed to maximize usability based on what people said would make it useful. So fruits and vegetables, so that it could be across all cultures. Flexibility on which kinds could be purchased, and then both large stores and small vendors based on the way people said they were shopping. Unintended consequences. Paper vouchers have always been stigmatizing since we were talking about food coupons. Increased stress and hassle about having to deal with that system. Diversion to other family members because we want to focus on pregnancy, but people live in family groups, and the amount of impact on the pregnant woman is sort of determined by how many other people need that food in the house. And then the opportunity for opportunity loss of not investing in upstream solutions. So if we know that transportation or some other is the issue, then this is a fairly downstream solution, and perhaps we could do better on one of those upstream ones. People should just have thought of that. We may not be able to do that, but it should be a consideration. Go forward. And then you implement your program. So they're going to request a limited amount of food security services from a contractor to do fruit and vegetable vouchers. They're going to do the 9 months of pregnancy. They want to extend that into the first 1,000 days of life. Some of these things are not set yet. They're just, they needed to get further for my presentation than they did in real life. So, and they want to add staff to connect people to employment and try to deal with some of those upstream problems. Is it realistic? Is it adequately sourced? So they don't think it's adequate to the size of the problem. So we're not going to get all women who need this support. It doesn't provide as much additional funds as the community requested. Many of the interventions that were implemented in COVID-19, some of those are in this, and none of those were sustainably funded. They were all kind of emergency cooperation and things that were done. And identifying staffing to bring together the partners who are going to be involved in this. And that means sort of creating a bit of a network so that we can do some collective problem solving about this issue. That is not included in the funding. And so they need to figure out a way to do that if it's an important part. Go forward. And then once it's done, and you could do this at multiple times, once it's funded, you could let community know and talk about who, as you're talking about the RFP, letting people know where that information came from. We asked people, and this is what they said. How you communicate what you're going to use to determine success. Outcome metrics, in this case, are going to be self-reported food security and consumption. client process metrics. So are we actually even doing this well? Client satisfaction. Are they using the vouchers? Do they say it was easy to use them, since we know that hassle is a barrier? And then just utilization metrics, looking purely at how many vendors give us back vouchers saying that they were used, and what's the dollar amount that we end up giving out. And then how do we message that based on what people know? So to partners, we need to address the broadening of the understanding of food insecurity as a social determinant, and that it has all these other connecting issues, because some of those people are related to those issues of childcare or transportation or other things. So looking at its the fact that it primarily is something felt by communities of color, and it's got lots of other drivers that others may have more influence on. And then staff to client communication is how it's going to reach the people involved. We do not have the funding to make it broadly available, and so the communication is going to be focused in the way the funding is on people who are actually signed in the programs. And that does leave out some people who we don't ever see signed up. Go forward, Mark. I'm going to stop there for questions about how that went. And I think we do have Paula and Preeti, who really were involved in trying to answer all those questions and get all of that data put out, much of which is not included in the presentation. Any questions?
Commissioners?
Commissioners?
I have
Commissioner
questions.
Gerardo? Okay.
Dr. Bennett, this is a great first start. I really, from committee presentation to this example, I very much appreciate it. And it's a good, as you said, it's a really good start to kind of fine tuning the tool to what we're looking for. One of the things in a number of the questions that I had submitted was really also on metrics in, I guess, in presentations such as this or going forward. What I had, my questions were like, what are the number of clients that are projected, to be served? Is the duration of the program you're hoping for 3 years, with the 1,000 days? And would then data be collected at the end, during, and at the end of the 1,000 days? And I guess I was most interested too, then, would you be able to project or consider metrics at the end of the 1,000 days for your impact, such as kids are going to preschool, or what the impact is? I guess in that tool, I'm looking for future, impact, not just today, but going forward.
Right. So I'm going to let the others answer the program specific ones. What I'll say in reference to this as a model for the tool is that we need to be flexible based on what we actually have available. We don't always, people should be able to comment on it. So what we have in this case is some of these details are not worked out. They're somewhat imaginary. So they may have answers, they may not, and that's fair. But in this case, I would say that those are all questions about program quality. And I would stretch those to say, if you're getting unequal quality, one, you should have quality. And then if you're getting unequal quality, I would hope that there's some benchmarks in between, so mileposts, so that we don't get to the end and go, oh, that was terribly inequitable, we shouldn't do that again. So I think in this case, because equity is how we want the program to run, we don't want outcome metrics at the end. We want something that's process in the middle. Health conditions may not change. We may be doing intervening things, so you may not have a reasonable metric till 3 years, but whether people are using it equitably, feel equitably about it, you should be able to say. And so looking at what those client-based metrics are, I think will be really important that you see that people do have ways of telling if they're off track before they get 1, 2, 3, 4 years in. In this case, I would say they have that. They at least can tell you intermittently whether utilization is the same, whether or not people are signed up in the numbers that were expected, and
Yeah,
whether or not those numbers have the right proportion based on what they were intending to do, whether or not they're seeing it at the very variety of kind of stores that people said they needed. If we're not seeing it used at any of the small vendors, that begs the question of, are some of the people who said they were dependent on that getting what they need? Or are these people not able to use it as well? And that'd be a question you might then change your satisfaction on. So you should have things in the interim,
right.
and you should be
Okay.
able to see those outer metrics. But I think the outer ones are less the assessment I would make in the equity tool. Those should be in there, but the tool I want to be really clear with people is it's meant not to be, we did it and it's over. The tool
Right.
is a process of how you go about this. So getting back to the community, it may be at the beginning, it may be halfway through, who knows? It may be every time you talk to them in other ways. So we will see how that changes depending on what kind of program we're talking about. We do a wide variety of things in this department. It's really hard to tell how well any one thing will stretch to cover all those things. And then I'm wondering if Preeti or Paula has some specifics about those questions about how are we doing further outcome metrics after that 1,000 days that take into account that longevity? How are we dividing those?
No, I appreciate it, and I appreciate listening to you, Paula. I guess I'm getting so kind of in the weeds here because I use WIC for all of our families, and so I refer to it in we use it in our center especially in our feeding clinic, and so that's why I'm doing more of a drill down than I know is probably necessary in the long run. But these things, I think, if we can embed this in our thinking in the process, is what really, not just the specifics, but just.
But Commissioner, I think that you're making an important point, because usability is one of the things that we most often fail at and then don't know we failed. So we gave you this thing and you didn't use it. Shifting that responsibility for usability to us and not the community. They haven't failed if they know nobody uses it. We have. And what do we need to change based on what we heard that makes it more usable? And I think this sets us up to do that in a better way than to just put something out there and hope that people use it.
Yeah, I agree. That's where I'm going with also just the benchmark assessment in this process. So thank you. Yes. And whatever information you have, other information.
I love this program. So go ahead, Paula.
Yeah, I mean, thank you, commissioners, and thank you, Dr. Bennett, for this, just working together on this, trying out this tool. And also Preeti Rani, the Director of Nutrition for Maternal, Child, and Adolescent Health, is also on the call, so she may comment. I think we've kind of put out there, we know that nutrition is so important, especially for the first 1,000 days of conception, yet we're not meeting the need. And so that was somewhat aspirational in what this, using this toolkit, was that we would propose to expand the existing program instead of just being the first 9 months of pregnancy, expand it to the first 1,000 days of life, so till 2 years old for the child. Some of the things I think would want to look at is impact on child development, but also I think we would also want to look at impact on maternal stress and depression and family dynamics. So, it's very complex. I'll just, knowing that we don't have really all of that capacity to do this kind of a deep, sort of research, but we did, and Preeti really led this, partnering with researchers to actually look at the impact even of the $40 a month that we have already provided, and really appreciate the UCSF team that actually did that research. And Preeti, do you have anything to add?
No, thank you, Paula, and thank you, Commissioner, for this opportunity. Yeah, I agree with everything that Paula shared. I just would like to add to what Dr. Bennett was mentioning earlier around like having those in between sort of assessments for critical, even for when we were making this, what vendors, where people shop, all of that information, adding, making sure it's, it's easy. People were shopping for their WIC food, so making sure all of those vendors were on there. The vouchers, I know there was a questions around the vouchers, looking at doing cards instead, those types of things happen as we are having this reiterative process around looking at, is it working, not working, what changes we can make. And also, of course, yes, we do want to have those long-term metrics in the work that the UCSF team is doing currently with the intervention that we're having right now. And they've had some successful, at least initial data that they have shared on the impact of preterm birth and increase in fruit and vegetable consumption.
Would the two of you very briefly comment on using the tool? I wasn't the user, I was the compiler of your, your use and advisor. So just, did it change your thinking at all? How is it asking you to think differently than you already would have, or was it just writing things down?
To me, the thing that I noted was that I had to narrow, just using the tool and not knowing what the questions were was, I've already shared with Dr. Bennett just sort of the next time, just some things that would have been helpful. But when it came to the tool, I really realized the role of collecting data and how there's such a tension in the community level of, it's a struggle. It takes a lot of resources to collect data and to use it. And this was the one, I was so thankful that we had worked together collectively, both with, population health, maternal child health, UCSF, and even when it came to the data from the focus groups with the different cohorts of pregnant people or postpartum people, that was through a partnership with the Homeless Prenatal Program, with the Meta-funded project, with lots of other partners, including APA Family Wellness. And, it's just this role of collecting the data that was needed for this tool was pretty enormous. And I kind of realized that I have to, my goal when overseeing these funds was to really get the money in the hands of people to buy more food. Yet, to be able to make the case and understand how it's working, I really have to carve out more funds for that data collection so that we can really understand how well we're doing or not, or where to adjust. And Priti, do you have any comments?
Yeah, no, I agree with everything you said, Paula. That was definitely a big lift. I do appreciate the intentionality and the framework that it allowed us to, we did this work, kind of getting the money out, having the equity lens, but all of that was helped us bring all of those pieces together. And then at the end, Paula had shared with me the entire document, and just seeing it that way was really very, very helpful, where all of those pieces came together. So that framework was really helpful, I thought.
Part of the reason we chose them is they had already done their community engagement. If they had not, I think we will be challenged to move into the transition that was already intended for equity, which is supporting different parts of the department to increase their community relationships, not just having different groups for each question, but having a variety of different ways of already knowing what people feel about topic A or B, because we've already, and then maybe what we're asking is a very directed thing. Just building out that program, I think, will take some time, and we won't really see this fully flowered, I think, until we have that piece in place. But I think people can learn to use it. And Paula, hopefully the next person will have gone through the training before trying to use it. And that would be our intention before July, hopefully.
No, I agree with Priti also, the seeing it all pulled together. I was having to pull data from all these different parts of the last couple of years, but seeing it all together was really powerful. And I think we can, we really look at, kind of pushing ourselves to do more and to do better and to push the envelope on what the family needs. I think that was one of the things that I also saw from using this tool, that we can do more. And I just kind of, I saw it kind of became clear, like we're doing some things, but it's not enough and we need to do more.
Thank you, everyone. Commissioners, any other? Dr. Chow has a question.
Okay, Dr. Chow.
Yes, thank you. I really appreciate Dr. Bennett's presentation, and now I understand the colors, and I do appreciate that you've seen that racial equity for our department really needs to also include health impact and health equity, so that's the purpose our department works on. And so my comments, now that I understand it, I do think that the blocks and the layouts are appropriate. Although I would also agree with Commissioner Gerardo, as I put in my letter or note to you, that I think we need to understand better the baseline and better the outcomes expected, and what sort of time frame that is, so that you're really able to achieve more than just somebody saying that they thought it was great, or we used up all the food vouchers. Somehow there should be a health outcome that we're expecting, and some of that, I guess, is in the sample. Were there improved outcomes for the child? Things like that. And I really think that's really, it's not a process outcome, but it's got to be a health outcome in my mind.
So thank you, Commissioner Chow. I am very happy we got to the health impact part. We won't be able to do it for every kind of project. We do lots and lots of things, but I do think it's important for us to be setting actual goals and then trying to achieve them. We have struggled, at least as long as I've been part of the department, and even when I was a provider, to be able to have that sort of health impact, full epidemiology and data that's required for that, predicting in a real way how many people might be impacted in terms of pregnancy outcome. One, the program may or may not have enough people to power that kind of conclusion. And two, we're going to have to figure out how much support people are going to need in order to deal with those metrics when they set them. So I don't want people to set metrics and then we don't have the epidemiologic or IT support to actually be able to run that data and be able to get something out of it, particularly not if we're all going to spit it out at the end when the thing's already over. I'd like to know midway. What we can do, and this would be one that would be expected in this, is even not just process metrics, but maybe not the full outcome. So are people eating better? Do children get into other daycare, or are we seeing less of some other condition that's maybe not the biologic one that requires as much data? Part of the research is not just to find out what number you want, but what are the interim things that contribute? So is there something like weight gained in pregnancy, which is correlated and we know we can get, but isn't necessarily number of preterm births because we don't have enough for something that uncommon. So there are things that we can do, I think, and it'll depend on the condition, and it will require a little bit of support for people in terms of thinking that through. And so that's one of the things we're trying to work on, and one of the reasons I think we need time to figure out how much we can support, when we're going to do this, and how to make it fit the various things that people want to use it for. And some of that depends on what you want us to focus on first. Is it health impact things? Is it things that have contracts? Is it where are we kind of focus our energy to see the first set of results around tracking and holding accountability for racial equity?
Well, I really do appreciate that we're part of the conversation in developing this, because this makes us feel, or at least me, that we're not isolated from the process. So I guess I had a comment that in order to choose the proposals, that of course is a challenge. You don't have to answer that yet as to what criteria you're going to use, because there is just such a multiplicity of issues. I think it's very appropriate, and that you're driving for data review. So that does help inform. And in this particular example, your data showed Pacific Islanders were impacted. And yet the study, of course, doesn't include Pacific Islanders in any of the charts in your pie charts. And then your engagement included Chinese participants, but I didn't see any Pacific Islander participants. I'm not making a fuss about that. I wanted to make a case that the disaggregation is really important for the Asian community and, well, I should say Asian and Pacific Islander community, because we're put together by the government, right? And that and this is sort of a theme even for later this afternoon about the racial inequity and therefore and where some of the Asian hate issues come from. That there's an inequity, but we can't answer the inequity in health in Asians unless we really disaggregate it, right?
Right. So one, we're going to have to deal with the small populations problem. We have some populations that are small enough that we never do deal with their data because we can't get results in the same year. It's not stable, but we have to have some kind of standard at which we separate their data and do 3 years or do whatever is necessary to include them, but they are often dropped off. Native Americans, Pacific Islanders, 5 years from now, African Americans. So we need to do something about having a policy around what to do with small populations. But that disaggregation, I think in this case, it really points to the fact that those focus groups were done with a different purpose at a different time. So, and that they were not looking at necessarily just the connection to preterm or to peripartum issues, because there is food insecurity in that Chinese community. There's a lot of food insecurity, but we don't necessarily see that leading to an increase in those perinatal issues, but it may be leading to others. So there's complexity in it, and people have to pick a focus, and they might have done the focus groups differently if this had been the driver. But we're always going to have limited information. It's too complex a problem to really be able to have a fully matching data set, and it's always going to be extrapolating and trying to figure out how much we need to know in order to make a change in the program.
I don't question. Nothing is perfect, and certainly in a city less than 1 million, we're not going to have it. And just to even recognize that there are smaller groups that need it, but I think, as I'll probably speak to later, the fact that API has been merged together sort of mask many of our problems. So when you're looking at proposals, I'm concerned that sometimes if all we're looking at is disaggregated databases, some of the proposals for our communities of API will not surface, and I'm not sure exactly how you would handle it in our small city. But being that we have a third Asian population, but cutting it down is probably basically right. Chinese, the Vietnamese, the Filipino, if we include that, well, they're within the API, and whether they're PI or Asian seems to be a challenge, but they should be spoken to. And they, by disaggregating, we won't have to worry if they're A or PI. And each of them have their issues. Each of them would raise to a health equity issue. And if we were then adding the racial lens, which is why I like the racial lens as you've been adding, because that does require that we try to break some of that down, and we've not been able to do that for these years I've been here. Because I don't think it's that the data is small, it's that often it looks like when we merge bimodally, two different classes of people, right? You just said the Chinese certainly do need food. Well, yes, that group of Chinese do need food, but there's a whole group of people that didn't. And then when you aggregate it as Asian, then you don't even see that as an issue, right? And And that's where I'm looking that this type of tool should also take that into consideration to find the problems.
Yeah. So I think first, we do not aggregate Asian and Pacific Islander unless we're reporting, at least that is meant to be our internal standard, unless we're reporting to a body that insists on it. So the law, it was changed at a state level. They are not as good at enforcing it, but we in the city, at least with our data, have been fairly good at it, but it means we drop them all together, which is not an acceptable sideline. So people get lost in the average. So I'm not sure it's good to have them buried, but it's also not good to have people never mentioned. So figuring out what a standard process might be, giving the data and telling people it's not statistically significant, giving a 10-year number to compare it to instead of a 1 year. I don't know. We really need to talk about that as a group. But that is a problem we have to solve. We're getting closer to being able to do it because we are collecting data that includes national origin, ethnicity, and language in a way that we didn't do before. So certainly in our patient population, we can break it down to that level. But that means you may give up on quantitative results. If you get down to tiny groups, you don't have the statistical power you had before, and you may have to deal with qualitative results or be content with, a probable effect rather than being able to have some statistical support for your effect. But I think we can live with that as long as people understand that that's what we're doing. So.
And I would agree with you. We've been doing community participatory research, of course, for like about 15 years under our ANCART cancer grant. And that's where I learned that you really just have to disaggregate. I mean, the Cambodians were different from the Laotians in their very serious issues. The Filipinos actually had higher breast cancer than I even had thought. But that's how you would then be able to come to proposals that would also then fit the racial and health equity. And there is national data now that does that.
We have to actually cut you short, Dr. Chow, because it's almost time.
Oh dear. Yes. Well, we can continue that dialogue a little bit later. Okay.
Thank you.
Dr. Chow and I got going. Move on.
So with your permission, Commissioner Chung, I'm going to quickly check to see if there's any public comment before we close the meeting out, because there are people in the other meeting room. Any public comment, please press *3. Those of you who are on the list. All right, I'm not seeing any hands. So commissioners in the room, if you'd like to consider a vote for adjournment.
Do we have a motion for adjournment?
I would move for adjournment.
And I second. So the meeting is now adjourned. Thanks so much for such a rich presentation.
Thank you, everyone. And Dr. Bennett, we'll see you in the next meeting very soon, and maybe this conversation can continue.
Yep.
Bye-bye, everyone. Thank you.
Thank you.